Hello, everyone, and thank you for joining us today for this very important session titled Home Dialysis for All, Building Trust and Access in Underserved Communities. My name is Ria Suarez, and I am Director of Outreach and Strategic Partnerships here at the American Kidney Fund. I'll be serving as your moderator for today's session. Our previous sessions have explored your choice of home dialysis, mental health, and adapting to home dialysis. In this session, we're turning our attention to a critical issue, access. Even though home dialysis can offer better health outcomes and flexibility compared to in-center hemodialysis, it is still underused in many communities, especially among Black, Hispanic, Latino, and rural populations. In our session, we will discuss those barriers and hear from experts and advocates about how we can work together to make home dialysis accessible for everyone. Let's meet our speakers for this session. Crystal Higgins is a two-time kidney transplant recipient who's experienced dialysis treatment for over a decade. Diagnosed with kidney disease in 2010, Crystal has navigated both in-center and home dialysis, using the latter to maintain her career, education, and independence. Despite a strong family history of kidney disease, Crystal continues to live a full and inspiring life. Welcome, Crystal. Miriam Velez Bermudez is a health services and equity researcher and postdoctoral fellow at the University of New Mexico School of Medicine. Her research explores how psychosocial and sociocultural factors influence disease outcomes and how institutions impact patient and provider behavior. Dr. Velez Bermudez aims to engage with community members and patients to create culturally concordant interventions that improve chronic kidney disease-related patient care. Welcome, Dr. Velez Bermudez. Matthew Sinclair is Assistant Professor of Medicine at Duke University's School of Medicine, the Duke Clinical Research Institute, and a staff physician at the Durham VA Medical Center. Dr. Sinclair joined the faculty of the Division of Nephrology in 2021, where he conducts research focused on reducing chronic kidney disease progression in underserved communities through community engagement and implementation of evidence-based care. He enjoys traveling and spending time with his wife and two sons. Welcome, Dr. Sinclair. Thank you, Crystal, Dr. Sinclair, and Dr. Velez Bermudez, as well as you, the audience, for joining us as we hold this important conversation to discuss increasing access and trust in home dialysis in underserved communities. Before we get started, I want to encourage everyone to please type your questions and comments into the chat box on the right of your screen. We will try our best to get to all of your questions during our Q&A segment at the end of this session. All right, I would like to start off with you, Dr. Sinclair. Could you briefly discuss what chronic kidney disease is, how it progresses to end-stage kidney disease, and why a patient would need dialysis?
Sure. Thanks for the kind introduction, Ria. I'm very happy to be here. Welcome to the audience. So chronic kidney disease is a process. I like to think of it as 5 different stages, going from essentially normal kidney function in CKD stage 1 to end-stage kidney disease, or the need for dialysis or transplant, which is at the end of kidney disease stage 5. And there's a whole range of stages within there, stage 2, 3, and 4, which are measured by something called estimated glomerular filtration rate. Now, this is based on a blood test that is done. It can be done at your doctor's appointment to kind of see what your kidney function is normally. A normal kidney function is usually above 90%. Most people, when they end up on dialysis, it drops to about 15% or lower. Now, there's a lot of things that cause someone's kidney function to go from normal to then progressing to end-stage kidney disease. The 2 most common causes in the United States are type 2 diabetes, or diabetes in general, and hypertension. And the problem with these underlying conditions is that they're mostly silent. So most people do not know when they have diabetes or high blood pressure unless they've been checked for it until they get to a stage where it becomes very severe. And unfortunately, if that happens, a lot of times patients will come in and be seen in the emergency room or by their doctor because they're not feeling well. And if they're not feeling well because of kidney disease, oftentimes it's at a later stage. This kidney disease itself is usually pretty silent at earlier stages. So this brings up to checking blood tests every year, we're also checking for high-risk groups urine albumin, which is a type of protein, because albumin in the urine is kind of a marker of kidney damage to come. And by doing these things, we're able to kind of prognosticate people, tell people where they lie in terms of their risk of progression and what kind of strategies we should be using in order to prevent them from progressing to needing dialysis. Now, when someone gets onto dialysis, I guess let's back up a second. So right before someone gets onto dialysis, we usually try to prepare them. So that means when someone's kidney function is about 20% or less, we want to talk about getting them a dialysis access. So what dialysis does is it cleans the blood through a machine. It's either done through the vein, either in a catheter in your neck or your groin, or it could also be done through something called a graft or a fistula, which is a permanent access that's created by a surgeon that uses your own blood vessels and or synthetic material. Typically, nephrologists prefer that patients use the graft or fistula because they tend to be less prone to infection. So oftentimes when someone's kidney function falls to 20% or lower, we'll get someone set up with a surgeon to discuss the placement of a graft or a fistula ahead of them needing dialysis. There's another type of dialysis called peritoneal dialysis that happens through the belly. So instead of using a dialysis machine with a filter, it cycles your own it uses your own membrane in your abdomen and cycles something called dialysate, which is basically a fluid that exchanges the dirty fluid in your body for clean fluid. Basically takes out the bad things and puts the good things back. We'll talk more about this as we go on throughout the session, but a lot of people would prefer to do peritoneal dialysis as opposed to hemo for a number of reasons. When someone is on dialysis, if they are doing hemo, it's usually, if it's in center, it's 3 times a week. So these sessions are usually anywhere from 3.5 to 4.5 hours, 3 times a week, not including transport and setup and all that. And then in between, you don't need any kind of treatment. If you're doing home hemo at home, it's usually about 5 nights a week. They're longer sessions, typically at home, but again, you're doing it on your own schedule. And then peritoneal dialysis is usually a daily type treatment. And the reason we do dialysis is we want to clean the blood from toxins that build up. Your kidneys do a lot of things. In addition to making urine, they're actually clearing toxins from the body and getting rid of those toxins in the urine. So if your kidneys can't do that, that's what the dialysis machine does. Also gets rid of extra fluid. So if your kidneys aren't working right, you're not making enough urine, fluid will build up, and over time that's going to cause problems such as breathing issues or swelling or edema, or potentially problems with the heart. As far as eGFR, so eGFR is kind of how we determine, again, if somebody is progressing. It's based off of a marker called creatinine, which is a muscle breakdown product. It's an important thing to understand because for a long time, eGFR was put into an equation that had race as part of a coefficient. So there was a black race coefficient, and this is based on earlier studies where they had looked at Black and non-Black individuals undergoing dialysis, Black and non-Black individuals, and were measuring their creatinine clearance or their GFR, and then using the equations to estimate. And what they were finding was at the same ages and the same creatinine levels, Black individuals tend to have higher GFRs than white individuals. And what this meant is they put a Black coefficient into the equation that would then for the same creatinine level would show a Black individual as potentially having a higher GFR than a white individual. In recent years, we've kind of realized this is problematic for a couple of reasons. One being that race is a social, not a biological construct. So it was kind of being used as for ancestry, and obviously, most Black people will have African ancestry, but it's a different amount of ancestry in different people. What about other people who may have African ancestry but don't necessarily identify as Black, such as Hispanics? How are they involved in these equations? So after a lot of deliberation, the decision was made to remove the Black race coefficient from the equation. So the current equations we're using do not have a coefficient. The result of this is that for the most part, the results are fairly accurate. It will now show Black individuals' eGFR as being a little bit lower than it would have previously. And the benefit of this is that for a long period of time, Black individuals were ending up getting care later on, or oftentimes ending up on dialysis at higher rates than white individuals. And by removing this coefficient, we've kind of leveled that playing field a little bit in terms of Black individuals being able to be seen earlier and hopefully referred for transplant earlier as well. There are other markers called cystatin C, which I won't get into right now, but that's another marker that's not influenced by muscle mass and things like that. So ideally, we could use that along with creatinine to estimate GFR. So I think that's a pretty good overview. We'll get into some more details about dialysis types and talk about some of the other barriers to care as we go along. But that's a kind of a quick overview to dialysis and CKD.
Thank you, Dr. Sinclair, for providing that overview of kidney disease and dialysis. So during my intro, I made mention that home dialysis is underused in many communities, namely among Black, Hispanic, Latino, and rural. Dr. Velez Bermudez, could you discuss why that is and what could affect the use of home dialysis in these communities?
Sure. So first, thank you so much for having me. One thing that's important to mention is that along the kidney care continuum, even when you're high risk with diabetes or hypertension, all through kidney failure, there are barriers, or there is the potential for barriers at every step of the way for all patients. However, what national trends reflect and what research reflects is that these barriers tend to disproportionately affect Black and Hispanic patients. So one thing that tends to be a barrier is there isn't standardized screening guidelines in primary care for testing or for screening patients for kidney disease, even if they are high risk, meaning they have a diagnosis for hypertension, diabetes, they're 50 to 55 or older. So this tends to make the decision to screen or test for kidney disease to be up to a provider's discretion, to be up to whatever clinic priorities are, which means there's a lot of variability. And given the fact that national trends show similar prevalence or similar rates of early stage kidney disease across all racial and ethnic groups, but then once we get to kidney failure, you see that Black, Hispanic, Native American patients tend to have higher rates of kidney failure compared to non-Hispanic white patients. That seems to suggest that patients who are not white are getting referred to nephrology or getting treated for kidney disease at much later stages, potentially after their kidneys have already failed. Dr. Sinclair already spoke about the shortcomings of the eGFR metric, and while there have been very meaningful measures to reduce the effects of having that race correction for eGFR, not all clinics in the United States have adopted a different type of correction. So there are going to be some smaller clinics. There are even some under-resourced or resource-constrained academic hospitals that still use a race correction, but try to also use other clinical information to make a better judgment on whether patients should be starting to be evaluated for transplant or having discussions about home dialysis versus in-center. And so some of these issues, although there are also, patients themselves can always advocate for themselves. They could also take care of their health, which could help them. They could not take care of their health, which would not help them. But we wouldn't see these national trends if there weren't issues at the systemic level. So if patients are experiencing delays with referral to nephrology, just identifying that they have kidney disease, if they're experiencing delays in terms of their staging once they are diagnosed with kidney disease because of this erroneous eGFR correction, then by the time they reach kidney failure, they may not be medically eligible for home dialysis any longer. And so although this is a really large issue, these are some of the things that might affect why Black and Hispanic patients are less likely to undergo home dialysis. So in general, they're less likely to have a functioning transplant, less likely to be on home dialysis, more likely to be on in-center dialysis. If they do get transplanted, they're less likely to get a transplant from a living donor, all compared to white patients who also tend to have comparatively lower rates of kidney failure. We can get into details, and if anyone has questions, please feel free to ask.
Great. Thank you, Dr. Velez Bermudez, for describing some of those barriers to home dialysis use. And just as a reminder to the audience, we'll begin the Q&A segment shortly. So please remember to type your questions and comments in the chat box to the right. Now, turning it over to you, Crystal, in your bio, we learned just a little bit about your experience with chronic kidney disease. Could you walk us through your CKD diagnosis and your experience with dialysis?
Yes, sure. Thank you, Ria. Well, I was sort of asymptomatic at first. I didn't have a history of hypertension or diabetes. I just felt tired all the time, and I had a strange metallic taste that developed in my mouth. So I went to see my primary care provider, and she ran some tests and told me that I was critically anemic. So I went to she told me to go to the emergency room for an emergency blood transfusion. And there I had it was discovered that I had renal insufficiency. My EGFR was low. I think at about that time, it was about 18%. And I had a renal biopsy, and I was found to have the collapsing variant of focal segmental glomerulosclerosis. So I started dialysis about 6 months after my diagnosis, and I enlisted for kidney transplant at Northwestern Medical Center in Chicago and at Vanderbilt Medical Center in Nashville. And at Northwestern Medical Center, my nephrologist suggested that I see a geneticist when I told her that there were several of my family members that had kidney disease, some of whom unfortunately have passed away, but just cousins and uncles, and my mother was recently diagnosed with kidney disease. So I was found to possess, to have the APOL1 gene. So I live in northwestern Mississippi, and I thought it was odd that I would never get bit by mosquitoes. And they said that, well, that's one of the sort of characteristics associated with the gene. It was to help prevent people from, of Western African descent from contracting malaria. So I started in-center dialysis, which I performed for a few years, and I ultimately got married and moved to northwestern Mississippi. At the time, I was living in New York when I was diagnosed. And my closest dialysis center to my home was actually in Memphis, Tennessee. And that was about a 25-mile drive from my home. I didn't want to have to make that drive 3 times a week, feeling tired from a 4-hour treatment, not being able to work and having to adjust my life and my schedule. I have a 15-year-old daughter, and I had to adjust my life and my schedule to be able to pick her up and take her to and from school. So I ultimately decided to try home dialysis, which I performed for about a year or so. There were a lot of supplies involved with the home dialysis, but I liked the freedom to sort of make my own schedule, to be able to schedule my treatments so that I could pick up my daughter and take her to and from school. And also, I felt that having more frequent dialysis treatments would be overall better for my overall health. There were fewer dietary restrictions, fewer fluid intake restrictions, and I felt better between treatments. I wasn't as tired or sometimes nauseous or dizzy. My blood pressure was better managed with the home dialysis as well.
Wonderful. Thank you, Crystal. Thanks for sharing your experience with CKD and the path that led you to really choose home dialysis as the option for you. So now we'll open it up to the full panel for a few questions before we turn to the audience for the Q&A. So for the first question, Dr. Sinclair, what do you see as the biggest barriers to offering home dialysis to patients, specifically within underserved communities in your clinical setting?
Yeah, great question, Ria. Before I answer, I just want to acknowledge Crystal and thank her for telling the story. It's not easy to talk about such personal details, and obviously experience to end up on dialysis, especially when you didn't know anything was wrong with your kidneys beforehand. So thanks, Crystal, for kind of giving us a light into this process you went through. I do also want to highlight that you said something about peritoneal being more, you felt better and it felt more natural. And I think the reason for that is you're doing a little bit every day as opposed to hemodialysis, which oftentimes is a lot in a short period of time. You're basically trying to replicate the entire function of what your kidneys do 24/7 in 3 days. Or 4 hours a day for 3 days. With peritoneal, you're doing for longer periods of time, but it's every night. So it is much more of kind of a natural type of process. So you may not be doing as much for each session, but because it's 7 sessions a week, it's some kind of a much more natural thing. So I think that is something that is really important to understand. And it's a good segue into what are the barriers. So I think, first of all, understanding the differences, right, between how you may feel between hemo and peritoneal. Most nephrologists themselves have not been on dialysis, right? So they're only talking from their own experiences they've seen in patient populations. And a lot of, I'd say 90% or 90% plus of our patients in training are on hemodialysis. It just tends to be the preferred modality in this country. And I think part of that is financial incentives. For a long period of time, there's not really an incentive to get people on home modalities, especially peritoneal. It takes a lot of training, it takes a lot of time, it takes a lot of efforts. And older physicians nephrologists were just not being trained as much in peritoneal and weren't really offering it to the extent that they probably should have been. I think that's changed, in the past few years from the federal government to kind of get people not only onto home modalities, but also get them early evaluations for kidney transplants. So I think that's a good thing, but it still takes a long time for things to change, even when it's a policy is being emphasized on the federal or state level, for it actually to trickle down to real changes on the healthcare system or individual level. The other thing is I think there's a lot of bias. I think we see our patients with kidney disease. A lot of them may have a lot of comorbidities, right? Some of them maybe aren't always completely adherent with their medications, and there may be reasons because of that. Maybe they're having side effects. Maybe they can't always afford the medications, and they're embarrassed to talk about that, especially in communities that may be marginalized or lower SES. And then maybe doctors are seeing that, and they're saying, well, if they can't even take their blood pressure meds or their diabetes meds, then how are they going to be able to do this treatment themselves, every night, until they either get a transplant or for the rest of their life. And so I think a lot of, physicians kind of make this paternalistic approach, maybe to not even broach the topic, when in reality, they're underestimating what their patients could do. And unfortunately, this leads into kind of, the default being in-center hemodialysis. And I think the ramifications of that is that it takes away people's autonomy to some degree. People are not able to move their schedules around or work the way they would be if they were doing it at home. And it kind of creates this loop where people are become dependent on the system in terms of, having to, either use transport or wait on the technicians or the nurses to hook them up and be stuck in a place for 4 hours as opposed to having that autonomy. And especially when it's younger people that this is happening to, it could be really devastating mentally and physically. The other thing I think is mistrust, right? So there's a lot of mistrust on the patient side too, specifically in African-American communities and Hispanic communities. There's been a lot of, unethical practices in the past. Some of you probably know about the Tuskegee studies and the syphilis study that was done back in the 30s. And on African Americans, and people have not forgotten that. They remember, what happened to their communities and how there was a lot of bad things that happened, and we've had to work to build that trust back. And I think sometimes it's hard to get marginalized communities to trust that we have the best intentions in mind, and that's something that has to be earned. And I think by kind of increasing cultural competence and also increasing representation, in medicine of minority groups, that's one way to kind of start building these bridges back. But I'm going to go ahead and hopefully that answered the question.
Great. Thank you, Dr. Sinclair. And that was a good leadway to our next question for Crystal. In terms of trust, what role do you believe trust or mistrust in the healthcare system played in your decision and experience to be on home dialysis?
I feel trust versus mistrust played an important role. I understand that providers work hard for their education and their licensure and their certificates. So I have faith in them to do everything that is within their power to help their patients. And it's also important to advocate for yourself if you're facing an issue, if you feel uncomfortable about anything, it's very important to speak up because there may not be anyone else to speak up for you. So that's something I had to learn to do for myself.
Great, thank you, Crystal. And again, for you, Dr. Sinclair, how do you approach conversations about dialysis options with patients who may be hesitant or lack support?
Yeah, I think starting early, right? So I'll start talking to patients about potential dialysis, well before their eGFR falls below 20, just to kind of preemptively make them understand that this is a real possibility, and it's going to take a number of visits to really understand what dialysis is and what's going to be the best option for them. Sometimes people aren't ready; they don't even want to talk about the topic, and that's okay. That's why we start early. I sometimes will offer them, tell them to bring a family member or a friend if it's either too emotionally taxing or they don't have the health literacy themselves to kind of understand what I'm trying to explain. Sometimes having someone else there to take notes down so they could just listen is really, really helpful. The other thing is relying on other members of the healthcare team. So I'm fortunate to be at a place where we have amazing nurses and medical assistants and social workers and nutritionists and dietitians. And some of them offer CKD education classes. So, I may only have a 20-minute visit with a patient to talk about, their labs and their blood pressure and their diabetes and their risk of progressing their kidney disease. But these classes may be a half hour or an hour. They could just talk about dialysis modalities or just talk about, what their goals of care are, or talk about things that are really important to them. And with somebody who's not a physician. So that sometimes is empowering too, to talk to other members of the team. As a physician, we do a lot, but we need to be able to, I think, defer to other experts. And there are a lot of experts who are able to do these things very, very well. And then the last thing is just leaving time for questions, and framing it in a way that you're telling the patient you really want their feedback. So instead of saying, do you have any questions? Maybe say, what questions do you have? So just sometimes the phrasing and just the way you word something can make a big difference for patients.
Great. Thank you, Dr. Sinclair. And Dr. Velez Bermudez, what kinds of innovative approaches have shown promise in improving access and equity in home dialysis uptake?
Yeah, that's a really good question. So I guess I first want to share, I'm a social scientist by training, so I think it's important to share my biases. I think systemic and clinic-based approaches are the way to go instead of putting the onus on the patient to self-direct their way to home dialysis when they may not have the resources to know if they're eligible themselves or know if they're a good candidate. So something some clinics do, which Dr. Sinclair alluded to, was offering kidney options classes. So at my former institution, they they mandated that every single patient who reached a GFR of 20 or below had to attend this kidney options class that was hosted in the clinic. It was essentially like an appointment that patients had to attend that covered all the home dialysis modalities. It included a discussion with the nutritionist, with the social worker, with the transplant coordinators, and a discussion with a real life home dialysis patient to talk about their experiences. And then at the end, a nephrologist would show up to answer all questions. And I was around this clinic for a long time. There was a lot of engagement in the class. And what this meant is that, some nephrology clinics can't help what experiences patients had before coming to them. But if there was a circumstance where a patient crashed into dialysis, they, felt sick, went to the emergency room, and suddenly are starting in-center hemodialysis, this gave them a chance to switch to home dialysis. And this was a very common practice in this clinic. And I think, if you are not close to a clinic in which this is something that is offered, because this does take a lot of resources, know that it is possible to switch. Even if you've already started in-center hemodialysis, it is not too late. If this isn't a clinic norm, it's still possible. So that's one example of something that some clinics are doing. Researchers are trying to also start earlier and try to utilize culturally concordant interventions, meaning they're trying to have physicians or interventions or community health workers or social workers be aligned with the local patient population. in order to communicate with them more effectively, and try to learn what are the specific barriers that might be faced in other communities that aren't necessarily reflective of the physicians that are in that clinic. And so I think offering resources within the clinic that is kind of just mandated for all patients once they get to a certain threshold for kidney disease staging or GFR, or starting earlier intentionally, and doing the work that would help the local community are some strategies we're doing to kind of boost home dialysis in Black and Hispanic communities.
Great, thank you for sharing those examples. For Crystal, in your experience, how do you advocate for your health, for your care, and that of your loved ones? Can you share any tips that you have with our audience today?
Yes, my, I guess, biggest or primary tip would be to become a sort of like a parrot. Just keep repeating what is concerning you or bothering you over and over again. If you don't feel like you're getting a result, or if you don't feel like your issue is being addressed, and tell it to as many people as you can. Someone somewhere, hopefully, will listen to you and address whatever is bothering you. So that was what I learned to do. I had trouble at first speaking up for myself, but I realized I have to take a leadership role in my own care. So if I don't speak up for me, no one else may ever speak up for me, and then I'll just not be heard, and whatever's bothering me won't be addressed. I also, because of that, I've learned to advocate for others, including my parents. As they age, my father lost his eyesight due to glaucoma, and my mother suffers from both kidney disease and dementia. So I learned to speak up for them. And I had a kidney transplant in July, and I started nursing school in Mississippi in August, almost 6 weeks post-transplant. So that I feel will help me in my future career as a registered nurse here in Mississippi.
Great, thank you, Crystal. And then on the topic of advocacy, Dr. Velez Bermudez, for people in underserved communities who face these barriers, what are some practical steps they can take to advocate for themselves?
Sure. So again, I already shared my bias. I do think that it is on researchers and physicians and policymakers to make changes for patients and just remove barriers, because it would be great if these outcomes were solely based on patient agency. The reality is they're not. However, in circumstances where the system or the clinic that you attend is not able to support you in the way that is necessary, I think patients need to be aware that they can ask for things. So knowledge is power, absolutely. So if you're a patient who has a history of kidney disease, a family history of kidney disease, if you have diabetes, if you have hypertension, you can always ask patients to test. I don't believe it is an expensive test. It's if they're already taking your blood, why not check for GFR as well, right? Later on, I think that you can always ask about home dialysis early, even if you are not yet approaching kidney failure, if you're maybe in CKD stage 3B. And the nephrologist should talk to you about that. And you can also see if there are resources that are offered within the clinic, or in the local community. I think given Crystal's history with the APOL1 gene, there are some clinics that do offer genetic testing. Not all clinics do. However, I think it might be reasonable to speak to a social worker, see if you can get your own private genetic tests and see if they can figure out a way to have that reimbursed for you. Because again, knowledge is power in circumstances where the system is not able to be as supportive.
Mm-hmm. Great, thank you, Dr. Velez Bermudez. Dr. Sinclair, so in the clinic, how can patients initiate these conversations with their providers, and what steps should be taken to ensure that actually leads to real access?
Yeah, great question, Ria. I'm going to piggyback on what Dr. Velez Bermudez just said about the fact that, yes, I agree that systems and providers and physicians should be the ones leading these conversations, but it doesn't always happen that way, unfortunately, for a number of reasons. And that's why you guys are all here, right? Why the audience is here, because you guys are getting informed today. So use this knowledge, use this as a jumping off point, and keep reading about it, and keep asking questions, and tell your friends and tell your family. Use these opportunities to learn these things so that when you have your visit, you can bring it up if it's not being brought up. And if your physician doesn't bring it up to you, let's say you're advanced CKD and they don't bring up home dialysis, say, hey doc, I've learned a little bit about home dialysis. Is that an option for me? Is that something that you were going to bring up? And if not, why haven't you brought it up yet, right? So put the onus on them to explain to you, if they haven't brought it up, why not? And would it be a proper option for you? The other thing is testing, right? So I agree. I'm very passionate about testing. So I agree. The blood test is very easy for the EGFR. That is actually done pretty regularly. The one thing that is not always done is the urine testing. So if you have diabetes or high blood pressure or CKD and your doctor is not checking your urine once a year, please tell them, doc, I need to have my urine checked at least once a year. You could say you heard it from Dr. Sinclair, but that is the guideline for people who have a risk factor or have kidney disease, because that is an early sign of progressive kidney disease before it will show up in the blood. So that's really important as well. And then leave the appointment with a game plan. So don't let the appointment end without having a follow-up game plan. If you're talking about transplant, then the next visit should be, okay, then when can I get listed for transplant, right? What are the steps to getting listed? How can I begin this process? If you're talking about dialysis access, then okay, do I have an appointment with a surgeon? Do I have an appointment with a nutritionist now that my EGFR is below 20 and I'm running into problems with potassium or phosphorus or calcium? Like, there should be an ongoing game plan. It's not a one-time conversation that's going to end and you have to start new the next time. It should be a relationship that you build, and it's on the onus is on the physician, but it's also on the patient to make sure that the physician lives up to what they need to be doing for you.
I just have one quick thing to add. Again, I mentioned knowledge is power, and I recently learned something that I found to be interesting and worth noting. If you are at the stage where you are unsure of your kidney disease status and you are in a clinic, a primary care clinic or a community-based clinic that maybe has trouble referring out to nephrology, I recently learned that some doctors will do the blood test and they will test, piggybacking off of what Dr. Sinclair said, they will test for EGFR, but there's a second measure, a creatinine measure, right, that they need to also collect, that if they don't have access to a laboratory clinic that's in-house, they may not know to request that second test. So, and then the GFR reading is incorrect. So,
I think it was statin C probably.
So statin C, I think there's UACR, right? So essentially, that's a problem out in New Mexico. That's why I bring it out. Some community clinics just test for EGFR. They don't have access to a laboratory, so they just ask for that measure and not the other one. Make sure, I guess Dr. Sinclair can clarify what I mean, but make sure you are getting the complete test done if you are at that stage.
Great, thank you. And thank you once again. Oh, go ahead.
Sorry, I just wanted to close the loop. So yes, so the EGFR is an estimation that's estimated with creatinine or another marker called cystatin C. Those are both blood tests. The urine test you're referring to, that's a urine albumin to creatinine ratio, and PCPs could do it. They could do both tests. So one should be a blood and one should be a urine. And that's the thing. You don't have to be seeing a nephrologist to get these tests done. And I think that's really the main takeaway here is if you have early stage CKD or don't even know if you have CKD but could be at risk, talk to your PCP, because even before you see a nephrologist, there's a lot you could do.
Great. Thank you, Dr. Sinclair and Dr. Velez Bermudez. And thank you to all our speakers for sharing your great insights on home dialysis uptake. So now it's time for our Q&A segment. Again, please type your questions and comments in the chat box to the right, and we'll try to answer as many as we can in the 5 minutes that we have left. So the first question that we have here, how much does your stomach swell on PD, in particular with those of us with very large kidneys due to ADPKD?
Yeah, I could try to take this one. So, there's different volumes of fluid that will be used for peritoneal dialysis, and it's typically based off of your body size and habitus. And some people can't tolerate as much fluid as others, but typically you'll work with your nephrologist to find the right amount that's able to do the job of cleaning the blood and taking fluid off of you while also not making your abdomen hurt. ADPKD is unique in that it's a specific genetic condition in which your kidneys get very, very large. And there are circumstances where if the kidneys are actually large enough that they're causing severe pain, sometimes there's indications to remove them. So that's something specific if you have that condition to definitely talk with your nephrologist about, because it can be very painful. And it does cause a decent amount of kidney disease in this country. Maybe not as prevalent as diabetes and hypertension, but if you know you have it or you have a risk factor for it, such as a parent who has ADPKD, that's something you should talk to your nephrologist about.
Great, thank you. And then this next question is for each of you. So what advice would you give to someone who's considering home dialysis but feels unsure or overwhelmed? And Crystal, we can start with you.
The advice that I would offer is to talk to your nurses, talk to your nephrologist. They can work with you to come up with a plan that works best for you and your situation, and they can tell you what your options are and what's available to you.
Dr. Velez Bermudez?
Yeah, I think you're allowed to have more than one conversation with your physician. And not only your physician, you're allowed to speak to, if you have access to them, some of the home dialysis nurses that only work with home dialysis patients and kind of have a really great understanding of all like the large possible range of things that can happen when you're on home dialysis. They can probably answer a lot of questions regarding the day-to-day. And they can also try to be flexible with you and try to make a plan of how home dialysis can work for you regarding your lifestyle conditions, and see if it really does align with your values. So if you're hesitant, I think it's still okay to make a decision later on down the line, and to continue having conversations with different providers if you're able to try to talk to a patient. But it's not limited to one clinical encounter. This is something that can be an ongoing decision-making process that can happen now or later.
Yeah, I agree with everything that Crystal and Dr. Velez Bermudez just said. The only thing I would add on is talk to other patients too. Hear from the patients themselves. Rhea could probably speak better to it, but I'm sure AKF has resources for patients to meet other patients who have done this. I know the National Kidney Foundation as well has a program where patients who are on dialysis or advanced stage CKD can talk to other patients who are not yet on dialysis and can talk about the risks and benefits. So talking to other patients, I think, really can make the difference. People who have actually experienced it themselves, more so than even just talking to the physician or provider.
Wonderful, thank you. And yes, we've dropped in some links for the audience to check out. So please do visit our website for some more resources and information. And we are just at time here. I can't believe how fast this session has gone by. But on behalf of AKF, I'd like to say thank you to our wonderful panelists and to you, our audience. Thank you for joining us during this session, and I hope you learned as much as I did. So coming up next is the session on advancements in home dialysis, a look ahead, which starts at 2:30 p.m. Eastern Time. And as we wrap up this session, you will see a link for a quick survey in the chat. So please take a few minutes to fill that out and tell us how we did. Your feedback will be very useful as we plan future sessions. Thank you, everyone, and have a great rest of your day.